Welcome back to It's Personal, brought to you by Gunderson Health System. I'm Chris Stauffer. Joining us to talk a little bit about what's happening in our community from an opioid standpoint, what we're seeing in emergency rooms, what we're seeing really in our backyards in some cases, is Dr. Chris Eberlein from the Trauma and Emergency Center at Gunderson Health System. Thanks for joining us.
Thanks for having me, Crosse.
Well, one of the things that we talk about when it comes to opioids is the overuse of opioids. We've heard about this now for a number of years. What I think some people get concerned about is that we're cutting back on painkillers, and then they're saying maybe we're overreacting. And what I'm getting at is they say people should be able to control that a little bit better. But then they're not necessarily always aware of what's happening in the community. And that's why we want to talk today about what is happening in the emergency room. What are we seeing in Little La Crosse, Wisconsin?
Well, unfortunately, we still are seeing overdose deaths in the community and overdoses coming into the ER. But what we have also seen is a big shift on how our healthcare providers are starting to react to this.
And that's kind of what we're talking about, is because some people say, well, I still want my pain medication. I still want I still need to feel better.
That and they have valid points, because we want to treat our patients and we want patients to get better, but we don't want to cause them harm. And as evidence has come out more and more, we're finding out that even short prescriptions, we used to think you'd have to be on these drugs for weeks to months to become addicted. Even short 3-7-day courses, you're starting to see 5% to 10%, 15% of the population in a year are still on these drugs they can't get off.
Is it true that some people who are reading more and more about that addiction and that potential addiction are choosing to forego painkillers altogether, even though they might be a candidate for it?
See it all the time now. And it's a good conversation we're having, because patients are coming in acute pain, and obviously if they need narcotics, they're getting them. But they are having that conversation prior to going home of, do I really need it? And it used to be, it was fairly much a reflex. They would go home with a prescription for a lot of the complaints for a narcotic. Well, now, and they're having that conversation, and we're getting more evidence showing things like Tylenol and ibuprofen taken together are actually better at controlling acute pain than 15 milligrams of oxycodone.
Okay, and oxycodone is one of those drugs that we're talking about, one of those opioids.
That's correct.
So I want to have you take us through what happens when someone comes into the emergency room and you suspect that this is an overdose situation, or you know it's an overdose situation. Take us through, would this be a Monday night, a Tuesday night, a Saturday night? What's the typical situation?
Unfortunately, there is no typical situation anymore. We're seeing these overdoses during the day, during the evening, at all times, all days of the week, holidays, weekends. So there really is not a typical time for these. But what ends up happening is the typical overdose is someone who's stopped breathing or is breathing very slow. They're turning blue. They're not responsive. And often from the history, you know that it was an overdose. Usually they come in by EMS. We have had several just dropped off at the door. And sometimes the people stay, sometimes they don't. I'd encourage everyone who brings someone in like that to stay. We're not going to prosecute someone in the ER for this, but the information that they give us is very valuable. So, especially on what they took and how long ago it was. And when the last time they saw them normal was is helpful as well. The thing that we make sure that we don't always jump to conclusions, obviously, in the ER. We want to make sure that we're not missing trauma, other things that can cause altered level of consciousness. So the immediate jump is not that someone's having an overdose in the emergency department. But once we get to that point, we immediately start resuscitation, breathing for them. And then if we think it's an overdose, we'll start to give them the antidote, which is Narcan, same that you buy over the counter now at Gunderson and other pharmacies, and that you can get a prescription for. And oftentimes that is not only the antidote, but it's diagnostic. Because if we give you enough Narcan and it's an opiate overdose, you will wake up.
Now, I think there's a lot of people out there that are thinking, how often is this really happening? You're saying, yeah, Monday night, a Saturday night, any time in the afternoon. But how often is this happening? How prevalent is this in our community? Is this happening once a month, once a week?
Well, looking at calls from EMS and visits to the hospital, now a lot of these patients are currently treating themselves on scene. And we know that from numbers of Narcan distributed through the AIDS Resource Center. And you're talking several hundred doses a year are given out that are being utilized. So from that standpoint, we know there are several overdoses a day occurring in our community. Not all of them are being transferred in. And of those that are, we're probably seeing 2 to 5 overdoses that are treated by either EMS or in the hospital a week.
How are individuals getting opioids? If we're cutting back on one end, how are they still readily available in the community? Where are individuals in our backyards? Because we're not talking about this as a specific area. We're talking about rural communities. We're talking about beyond La Crosse. We're talking about having to deal with EMS in rural areas, having to have Narcan now. Where's it coming from? What are you hearing?
There's a couple routes, and the one that we have the most effect on is the prescriptions. So people they get their prescription for 20 pills, they use 3, goes in the medicine cabinet. Either gets stolen, sold, something happens where that gets distributed to someone who wants to take it for reasons of getting high or not for what it was originally intended for. So that's why it's so important to use the drop boxes. We got to get all the narcotics that aren't being utilized out of the community. So when you're done with your prescription, make sure you dispose of it.
So these drop boxes, one of them being at Gunderson Health System, is a safe place to drop any kind of prescription drug. It doesn't have to be an opioid.
It does not have to be.
It can be anything.
Yep,
it's just a safe place.
Yep.
And then it doesn't end up in the waste stream or in the Mississippi River, for goodness sakes.
That's right.
That kind of thing.
Yep.
So talk, if you would, a little bit about the solution, because we're seeing the problem. It's not going away. It's. I know it's a concern for you. It's something that you've been advocating on a lot of different fronts, from the EMS level right to the emergency room, and then out into the community as well. What can we do?
I think, like I've said a couple years ago, this ship is going to be slow to turn. We've been going down this road. There's a lot of history built up to where we are now, and it's going to be a slow transition back to midline, and we're getting there. The first step is to control the prescriptions, because we know that 80% of the heroin users started with prescription drugs. So if we can prevent that initial abuse, we're ahead of the game. So between the prescription drug monitoring program, better physician and provider education on the appropriate use of opioids, alternative treatments for pain, we're starting to limit this supply appropriately. So patients that need pain pills are still going to get them. After we get to that point, we've still got this group of patients in the community that are addicted. And that is the harder part. Prevention's easier than treatment, and this is very, very true in opioids. So we need to get these patients into treatment and off of these drugs.
We're talking with Dr. Crosse Eberlein, Trauma and Emergency Center, a physician, and we want to talk to him more about opioids. But one of the things you just kind of lobbed out there was heroin. Heroin is another thing that we hear about in our community all the time, and I think you said it's sort of second base. Mm-hmm. It's the opioids kind of open up, if you want to use a baseball metaphor, get them on first base, and now heroin is second base. It's cheaper and easier to find.
Yes, especially now that we are restricting the opiate pills, and that it is an unfortunate consequence of this controlling the initial prescription pills, because a lot of these addicts are now jumping to these other more potent drugs. Addicts don't tend to start with heroin. I mean, this is a drug that it took some getting to, it took a while to get there. But once they're there, it's very hard to treat, and it's extremely dangerous because they don't know what really they're getting. And now we're seeing the fentanyl and carfentanil and the other synthetic opioids that are either mixed in or sold as heroin, because oftentimes, the reality is these are drug dealers and they are selling what they can get cheap and they can make a profit off.
So that's third base. Fentanyl is out there, and can you explain sort of what that is, maybe in a little bit greater detail, and how dangerous that is, not only to individuals who are taking this with heroin, but also to police officers, firefighters, first responders, EMS.
Yeah, so heroin is, if heroin is a 1 on potency, your fentanyl is about 100. And then if you go up to the carfentanil, which is another synthetic opioid, it's a 10,000. So you're dealing with tiny, tiny amounts to overdose someone. We use some of these drugs in the hospital. We don't use carfentanil, but we do use fentanyl in the hospital frequently. It is a great pain medication for acute pain. If you've ever had surgery, you probably had fentanyl. If you've ever had a colonoscopy, you probably had fentanyl. You ever broken a major bone and gotten IV pain medicine, that's probably what you got in the emergency department. So this is a drug that has great utility in healthcare. However, that's in a monitored, controlled setting, and I know exactly the dose you're getting. You don't know that when you're injecting what you thought was heroin, and now you get something that, and you're taking the same amount to get high like you did last time, but now you've got a drug that's 100 to 1,000 times stronger. That's where these significant overdoses are coming in.
It's not just significant overdoses, it's deaths.
It's deaths, absolutely right.
And as many as in, maybe not necessarily La Crosse, but I know you've talked about it before, that sometimes it's 3 and 4 within a short amount of time, and you wonder if there's a connection.
For sure, yeah. I mean, when these mixes come into the community, and it's much more important than what we've been seeing, you see these groups of overdoses. And nationwide, we're talking 60 to 100,000 people a year are dying of these opioid overdoses. And what we've noticed is that more of them are dying from the synthetics now than heroin a few years ago. And that's because these synthetic drugs are easy to mass produce in factories, and they're shipped in. And if you have something that's 1,000 times more concentrated, it's 1,000 times more easy to smuggle in. And that's where part of the problem is coming.
What do you say to somebody who's saying, "Oh, that's a problem in Milwaukee, Chicago, downtown Minneapolis"? What do you say to somebody out there listening when you hear something like that?
It's here in our community now. It is here, and it's been here for a few years. And every now and then we even get a stronger batch through, and we see these groups of deaths. And it is concerning, like you mentioned before, for EMS, first responders, police, fire, because some of these very strong synthetic opioids can be absorbed through the skin, and they are so small. A single a single grain of salt, you get that on you, get that in your mouth, will kill you. And so if you got a first responder, police, fire, who are taking care of a patient, they didn't realize they got that on their clothes. They, wipe their mouth on their sleeve, or it can even be absorbed through the skin. There has been cases of these sorts of providers becoming overdose from inadvertent contact with these medications.
It's another thing that they have to train for now. It's another thing for the individuals who are out there trying to save lives, may end up having to save their own lives or of a coworker,
of a colleague.
Yeah. So one of the things you mentioned was the grain of salt of the carfentanil, but that's not you're not going to typically find just a grain of salt.
Yeah, typically it's...
What are we finding out there? I mean, what are they finding in some of these larger communities?
Yeah, I mean, it's coming in, it's typically some sort of powdery solid. Now, it used to be thought that this stuff is always white, but the police have told me they're often dyeing it. So they found these drugs dyed purple, green, all sorts of different colors in the rainbow, and that's in a way how they market it.
And that's not Milwaukee or Chicago police who are having those conversations with you?
No. It is not.
What else is coming up? What else do we need to worry about? Because it doesn't seem like we've talked about first base, second base, and third base. What else is out there?
Yeah, I mean, the synthetics are going to be here to stay, I'm afraid, just because of the ease of getting them into the country, ease of production. The heroin actually has to be made from the poppy plant. And so you're able to actually, the military sees these things overseas, they're destroying the crops, things like that. So they've really shifted to these more powerful synthetics. And unfortunately, I just don't see that component of it going away. That I think is going to be here to stay in our communities for a long time. And what we're going to have to do is work on the demand side of things. And as we get these patients off these narcotics, have fewer patients starting these drugs and becoming addicted, that demand will go down. And in 5-10 years, my hope is that we will be out of this epidemic. But I think it's going to take that long.
Well, it's a little scary, but we like to give people hope.
Yeah.
What other resources are out there? Where can people turn if they are worried about someone they know who is on heroin or addicted to opioids or that kind of thing? Where do you go?
You can talk. There's actually a lot of resources in our community and more coming online all the time. If you yourself have a problem with opioids, you need to talk to your doctor, your primary doctor, and they can help you through the system. And we're working more and more with medication-assisted treatment to get people off of these drugs. Oftentimes, it is taking the place of the illegal substance that we don't know what it is and weaning these patients off of these drugs. But it takes time. It's frustrating for the patients, I know, but we have to keep working towards this goal of getting them off these drugs, that if they don't need them, obviously, but for those that are addicted, you need to talk to your doctor and get into the system and get the help you need.
Are there warning signs of someone addicted to, whether it's heroin or opioids? Is there something that is a common warning sign?
Common, probably not. I think everyone acts differently with their addiction. If you are on one of these medications and you have a lot of trouble missing a dose, you start to feel poor, nauseated, things like that. At that point, you have a physical dependence. But that is actually easier to treat than the mental dependence on a lot of these medications.
Very interesting. There's no doubt about that. I should ask you, beyond the warning signs, beyond how we're not trying to scare our community, but we also want to warn the community. And I know that that's something that you've been trying to tackle.
Yeah, we've been trying to more educate the community.
Right.
It is surprising me how many people have come up to me in the community and have recognized me from talking like this and saying thank you. They knew someone that had this problem. Mm-hmm. And I think the community was ready to hear this message. And I don't see panic in our community. I see more resolve in our community than panic. And that's a good sign. And
it's not an economic issue either.
No, we actually did a study, and it is across all socioeconomic boundaries this drug is crossing. And I think that's really eye-opening to a lot of people.
So when you're in asking for those painkillers and you don't get them, your advice is to say, well, maybe you don't need them.
Maybe you don't need them, and we're going to work at trying to give you something to treat your pain that will work and not cause you long-term harm, because that's really what we want to do. I don't want to hurt anyone, and none of the providers here do. We want to give them the relief they need, but we don't want to cause them harm 5-10 years down the road.
Yeah. Care has changed from where it was 10-15 years ago, that's for sure.
It really has.
Yeah, and we're seeing sort of the results of that, as you mentioned.
We are.
Dr. Eberlein, thanks for your time and for sharing your insight on this, and please don't stop what you're doing.
Thank you.
All right, Dr. Crosse Eberlein, Trauma and Emergency Center physician here at Gunderson Health System, joining us on It's Personal.